This is section 6, cardiac cycle and valvular heart disease. Oh, when you first look at this, it's kind of scary, isn't it? Oh, it looks kind of, oh, it's not scary. This is the Wiggers diagram. This is everything you ever wanted to know about the cardiac cycle, but you're afraid to ask. It's all right here, and very, very high yield for this exam. Okay, now let's start with very basic fundamentals. The heart does two things in systole. It pressurizes and ejects. The heart does two things in diastole. It depressurizes and refills. So systole, going to have two phases, a pressurization and ejection. Diastole, we're going to have two phases, a depressurization and a refilling. Notice the panels on the Wiggers diagram. The upper panel is pressure, the lower panel is volume. So pressure, volume during a single cardiac cycle. Now I want to remind you how the valves work. They're going to work based upon pressure differences. If pressure behind the valve is higher than ahead of the valve, then the valve will be open. All right, what do I mean by that? Just think of path of blood flow. So the right atrium is behind the tricuspid valve. What's in front of it? The right ventricle, because that's the path of blood flow. So if right atrial pressure is greater than right ventricular, the valve is open. Now, if the pressure in front of the valve becomes higher than behind the valve, then the valve snaps shut. So if right ventricular pressure is greater than right atrial pressure, the tricuspid valve is closed. And all the valves work the same way. So again, the atria represent behind the AV valves. The ventricles represent behind the aortic and pulmonic valves. They just open and close based upon pressure differences, basic hemodynamics. All right, we're going to start with the first phase of systole, and the name makes perfect sense. It is called isovolumetric contraction. If you look at the top where the arrow is, that's panel 1 on the Wiggers diagram. So here's panel 1. This is going to be isovolumetric contraction. Heart does two things in systole. It pressurizes and ejects. In the first phase, your mind, when you read the word isovolumetric, no change in volume. So this is the pressurization phase. This is the start of systole. And we know this is the start of systole. If we look down at the bottom, there's our EKG. Notice we're at the QRS complex. QRS complex is ventricular depolarization, which initiates the contraction. So you see the QRS complex, and then right as we get that QRS complex, within some milliseconds, we're going to start a contraction. We're going to do the first phase of systole, isovolumetric contraction. Now the lower panel is volume. Since panel 1, running vertically, is the first phase of systole, then the volume right before that, right before the start of 1, has to be in diastolic volume, because we're at the end of diastole, start of systole. That's the transition. So in diastolic volume is illustrated there by the arrow on the graph. And as we well know, in diastolic volume is very important because it is preload. All right, so we get the QRS complex. The heart starts to contract. We get isovolumetric contraction. In other words, we get pressurization. So ventricular pressure starts to go up. Well, right as ventricular pressure goes up, it exceeds left atrial pressure and the mitral valve snaps shut. So the aortic valve is closed, the mitral valve is closed, so the heart is contracting, but it can't eject. Isovolumetric contraction. What is it doing? Pressurizing. Now, if you look at the slope of that line, let's do a quick little review. Hopefully you remember back in section 4, the slope of that line would be, do you remember? Yes, very good. dP dt, change in pressure of the change in time. Okay, that's rate of contraction, would be the slope of this initial pressurization. Now, as that pressure goes up and up and up, eventually it exceeds aortic diastolic, the aortic valve pops open, and we go to the next phase, which is ejection. Heart does two things in systole: it pressurizes and ejects. So notice the drop in volume, ventricular volume, as we eject blood, and that volume that we eject is stroke volume. Initially, during ejection, ventricular pressure is going up, and then pressure starts to fall as the twitch tension starts to subside and the heart relaxes. Notice down at the bottom the T wave occurring during the second part of panel 2. So the heart starts to relax, pressure starts to fall. Now, once pressure in the ventricle falls below aortic pressure, the aortic valve snaps shut and we start the first phase of diastole, which is called isovolumetric relaxation. Since this is the first phase of diastole, this represents in systolic volume. Remember, in diastolic minus in systolic is stroke volume. So notice we are rapidly relaxing. The aortic valve is closed. The mitral valve is closed. So we are depressurizing. That's isovolumetric relaxation. You see a slight, what's called a reverberation. So it's a blip up in blood pressure in the aorta. This is called the dicrotic notch. This is a reverberation of pressure in the aorta because the aorta has elasticity. It is stretching out to accommodate this volume, and then it is snapping back, and once that valve snaps shut, you kind of bang against it, and that dicrotic notch is simply just a reverberation of that pressure. I only point it out because it helps us with time aspects. There's really no real functional role to the dicrotic notch, but if you see a dicrotic notch, then you know the heart has started diastole. Notice that the dicrotic notch occurs during isovolumetric relaxation. So again, the first phase of diastole is isovolumetric relaxation. We are depressurizing. Ventricular pressure is falling. Once ventricular pressure falls below atrial pressure, the mitral valve pops open and the ventricle refills. Now, an important aspect for us, this is the filling phase. An important aspect is most of this filling is passive. All right, now we go back to the bottom. We got a purple arrow came in, and you can see that it points to the P wave. The P wave is atrial depolarization. So right after atrial depolarization will be atrial systole. So the very, very first panel, vertical panel, represents atrial systole. Notice that we get a little bit of filling with atrial systole, sometimes called the atrial kick. That is not the major component of filling in the normal heart, especially in young, healthy individuals. Most of the filling is passive. We just have to open the valve. And the blood flows because atrial pressure is higher than ventricular pressure. So most of the filling is passive. Now, we do have instances where atrial systole becomes more and more important for ventricular filling. And that is when the ventricle starts to get stiff. So if I have a stiff ventricle, atrial systole becomes more important. That's that concentric hypertrophy of, say, hypertension or aortic stenosis. Could be a restrictive cardiomyopathy caused by, for example, sarcoidosis. But another example of when atrial kick becomes more and more important is as we age. So very high yield factoid for you. As we age, atrial systole becomes more and more important for ventricular filling. Where does that come into play? What's going to be the big thing for this on step 1? Well, AFib, the arrhythmia AFib. Atrial fibrillation is a non-coordinated electrical activity, so there is no effective contraction of the atrial muscle. And by effective, I mean the atria acting as a syncytium, all the fibers contracting simultaneously to push blood. That doesn't exist in atrial fibrillation. It is a chaotic, hectic, all over the place electrical activity. So there's no coordinated contraction. So it's not going to participate. There is no atrial kick, so to speak. This is reasonably well tolerated in a young, healthy individual. I'm not saying you don't treat it. I'm just saying it's reasonably well tolerated. It is not well tolerated in the elderly. And that's because that atrial kick is more important for filling in the elderly than it is in a young, healthy individual. All right, the very last part of this is I want to point out a couple of more high yield points. I just brought in 2 circles on the pressure. Notice, number 1, notice that diastolic pressure in the ventricle goes close to 0. It doesn't in the aorta. Remember, aortic pressure is 120/80. So diastolic is around 80 in the aorta, but in the ventricle, it's 0 or close to 0. That becomes very important if they don't give you a lot of detailed descriptions of a pressure wave. If they just give you a pressure wave on step 1, if the diastolic is going close to 0, then you know it's a ventricular pressure wave. The second circle came at the top or the peak of the pressure. Notice that there is very little difference. Very little difference. The graph shows they're identical. That's not true. There is a slight difference, but it's not big. There is very little difference between systolic pressure in the ventricle and systolic pressure in the aorta. All right, what does that tell us about resistance across the mitral valve? Hopefully you remember your hemodynamics. We have a small pressure drop. That means very small resistance. Very small pressure drop means very small resistance. Big pressure drop, big resistance. Small pressure drop, small resistance. So in the normal heart, the aortic valve offers very little resistance to blood flow. And that's a key point. So that's our Wigger's diagram. We're going to do it again in a little. We'll kind of redraw it on a pressure volume loop in just a moment. Very, very high yield. Don't be scared of this graph. The heart pressurizes and ejects in systole, 2 phases. The heart depressurizes and refills in diastole, 2 phases. And that's what this picture shows. Now, before I leave this is for the left ventricle. It will look almost identical if it were the right ventricle. The only difference would be the magnitude of pressure. Remember that peak systolic pressure in the pulmonary circulation, pulmonary artery pressure is only about 25, so it'd just be the magnitude of the pressures would be less. And of course we would change the names of the valves. Okay, next aspect for step 1 are the heart sounds. Pay attention, listen to the heart sounds. Do these before you sit for the boards. All right, the heart sounds are the sudden closure of the heart valves. This will yield systolic sounds. The valves on the left usually close first, while the valves on the right are first to open. We have 2 basic heart sounds, lub-dub, lub-dub, lub-dub. The lub is S1. This is produced by closing of the mitral and tricuspid valves. They close almost simultaneously. So really you can't pick up a difference with the human ear under normal circumstances. The second heart sound is produced by the closure of the aortic and pulmonic valves. During expiration, this is heard as a single sound. Again, lub-dub, lub-dub, lub-dub. But when I take a breath in, inspiration, this will increase venous return to the right heart and increase output from the right heart, and that will delay the pulmonic component. All right, again, the key is inspiration delays the pulmonic component. And it can be delayed enough that you can hear the difference in time between the closing of the aortic and the pulmonic. So it'll shift from lub-dub, lub-dub to lub-dub-dub, lub-dub-dub, lub-dub-dub. This is quite natural. This is called physiologic splitting of the second heart sound. But again, it's inspiration that causes it because inspiration delays the pulmonic component. That's the key. So those are two main heart sounds, S1 and S2. Here's kind of a pictorial aspect to look at the idea of the first and second heart sounds. Again, S1, you don't hear a split. You don't hear a difference, so you only hear it as one sound. The second heart sound can be subdivided into A2, P2, A for aortic, P for pulmonic, 2 for second heart sound. As we described on the previous slide, on expiration, you can't hear the difference. But with inspiration, you delay the pulmonic component, and now you can hear three different sounds. So again, you go from lub-dub, lub-dub, to lub-dub-dub, lub-dub-dub, lub-dub-dub. That's called physiologic splitting. Now this can get widened by pulmonic stenosis or right bundle branch block. If you have a fixed split, so notice the middle panel, the fixed split. So it doesn't matter if it's inspiration or expiration. The split is fixed, it is not influenced by a respiratory cycle. Then think potentially atrial septal defect. That's going to be your most likely answer. Now, notice the bottom panel. This is what we refer to as paradoxical splitting of the second heart sound. Now, in this person, notice that the pulmonic component is closing before the aortic. And you can hear that on expiration. So in expiration, you hear lub-dub-dub, lub-dub-dub. But then you ask the patient to breathe in, and the split goes away. Now we know that inspiration delays the pulmonic component. So the split going away with inspiration is telling us that in this patient, the pulmonic is closing before the aortic, because it's the pulmonic that gets delayed and the split goes away. Since I have a split in expiration but not inspiration, this is referred to as paradoxical splitting. A couple of things to look for that can cause that. For step 1, left bundle branch block and advanced aortic stenosis. All right, S1 and S2 are our main heart sounds, but there are also a couple of more. Third heart sound is called S3. This occurs right after opening of the AV valve. So this is where we're getting rapid ventricular filling. This is normal in children and young adults. However, the thing to look for on step 1 for a pathology here is a volume overload. Classic clinical presentation, clinical vignette for step 1. Patient X has an audible S3 or S3 gallop. So it's lub-dub-dub, lub-dub-dub, S3 gallop. You're thinking congestive heart failure. All right, that goes right at the top of the differential. That doesn't mean that it is congestive heart failure, but that definitely goes to the top of your differential. You're thinking, all right, we got a volume overloaded patient. Now, they may have aortic regurg, maybe something else, but it is a volume overloaded heart with S3, and oftentimes called S3 gallop. There is a fourth heart sound that occurs during atrial systole. This gets accentuated, and you may be able to even hear it if you have a patient with a stiff ventricle. So an audible S4, you think stiff ventricle. End of story. You think stiff ventricle. Now once you have stiff ventricle in your head, Then on your differential, you're going, okay, could be a concentric hypertrophy. That's very likely, like with aortic stenosis or systemic hypertension. Could be a myocardial infarction. Could be a restrictive cardiomyopathy. So again, S4, stiff ventricle. Now you generate the differential from there. All right, as I indicated before, pay attention, do some practice on hard sounds in your preparation for step 1. The other big thing to remember related to this are the sites of auscultation. Aortic and pulmonic are about the second intercostal space. Aortic's on the right side, pulmonic's on the left, both about mid-clavicular, but again, aortic on the right, pulmonic on the left. You get to move your little stethoscope around on these questions that involve heart sound. So if it's aortic, then it's upper right, pulmonic, upper left. For the AV valves, the tricuspid is about the 5th intercostal space, right at the sternal border, whereas the mitral is the 6th intercostal space, on the left side, again about mid-clavicular line. So remember these auscultation sites. May be very important for getting the right answer as to what valve is defective if we have a murmur. All right, the next aspect to cover related to this is called the venous pulse, and that's illustrated in the blue line on this figure, and there's my EKG running at the bottom. The venous pulse, we have several waves that we need to know, and the first wave is the A wave. Notice the big rise in pressure during the A wave. Pay attention to your EKG down at the bottom. This is occurring right after the P wave. So the A wave represents the increase in pressure during atrial systole. Next, pressure starts to fall, then jumps back up again, and that generates what we call the C wave. So the second wave that we see is the C wave. And this is thought to be mediated by bulging of the tricuspid valve. Now let's back up. Remember, this is a venous pulse. Could also be called a right atrial pulse. So we're on the right side of the circulation. So the direct valve we're looking at, first valve, is tricuspid. Now whether it technically bulges or not is not that important. Bottom line is we are contracting the right ventricle, snapping that tricuspid shut, and so there is a little bit of pressure reverberation back into the atria. That's the C wave. Next is the X wave. Notice that this is a fall in pressure. As the atria relax, pressure goes down, which hopefully makes sense. We have a little chamber here. We relax the muscles and the pressure falls. Then pressure begins to rise, and that is the V wave. This is associated with the venous return that is occurring during systole of the ventricle. Notice that the V is occurring during the very last part of systole and during isovolumetric relaxation. So we're not moving blood into the ventricle, it's just pooling up in the atria. That's what causes the rise in pressure. Next is a drop in pressure called the Y descent. This indicates the opening of the tricuspid valve. This drop in pressure is because we are now translocating blood from the atria into the ventricle. So pressure is dropping as that blood moves. So those are our waves, A, C, X, V, Y. A, C, X, V, Y. This is the terminology. Now let's talk about pathologic correlates on the next slide. Okay, now that we've discussed and gone through in detail the normal wave, now let's look at the big 3 pathologies to look for on step 1 for a venous pulse alteration. The first is AFib. Notice there is no rise in pressure, so effectively there's no A wave. Second big characteristic, notice that there's not a steep X descent. So there's not a big drop in pressure during atrial relaxation. And that's because with AFib, we have no A wave because we do not have a coordinated atrial systole or atrial contraction. And the atria aren't really relaxing either. It's just an uncoordinated electrical activity. So it's not a coordinated contraction, and it doesn't really relax. So no A wave, rise in pressure during atrial systole. That's the A wave. We don't see that in AFib because there is no coordinated contraction. The atria don't really relax. The right atrium's not going to relax in AFib because it's just got this continuous uncoordinated electrical activity. So that's the key characteristics to look for AFib. Now, for tricuspid regurg, we have a normal looking A wave, so the atria are contracting, but there's where it ends. That's the big difference. Notice where it should be dropping and then coming back up for a brief C wave, the C wave's gone, and in fact, pressure continues to rise when it should be falling during X. And notice this very, very high pressure at the end of the V. So we are reversing the pressure. Should be going down during X. But no, we have tricuspid regurg, so blood is coming back into the atria. So the atria are filling up with blood, and as a consequence of that, as a result of that, that pressure goes way up. Then notice, because we have a very high pressure at V, we have a very steep, wide descent. Now, if you get an abnormal venous pulse on the step exam, hopefully you'll get tricuspid regurg. If you do, you go, oh, thank you. Yeah, because notice, it doesn't look anything like normal. And in fact, it doesn't even resemble AFib or tricuspid stenosis, either of our other two abnormalities. This one is totally different. That rise in pressure when it should be falling in X, that very high pressure in V, and this big, deep, wide descent. All of those, they're just screaming to you tricuspid regurg. Last but not least is tricuspid stenosis. A stenotic valve is a resistor. So the big key characteristic here is a very accentuated A wave. Notice the very high pressure during atrial systole. And that's because the atria are contracting. They're trying to force blood through that tricuspid valve, but it's stenotic, so it's a resistor, so the pressure backs up. Okay, a tricuspid stenosis, a stenotic valve is a resistor. Remember what happens if to upstream pressure, if I increase resistance. The right atrium is upstream from the tricuspid valve. So when I increase resistance, hopefully you remember, upstream pressure goes up. So atrial pressure is going to go up, and the more severe the stenosis, the higher and higher that atrial pressure. Also, you won't see quite as steep, wide descent because, again, you have a stenotic valve that's a resistor. So those are the big three to look for abnormal-wise on the venous pulse for step 1. All right, let's do very quickly a little Swan-Ganz catheterization. Swan-Ganz, totally cool catheters we described earlier. It's got that little balloon at the end. You know, it's a flow-directed catheter. It's got multiple ports. It's really cool. It's a cool catheter. The idea is we want to measure pulmonary wedge pressure, pulmonary capillary wedge pressure. Now, we can't see where the catheter is going, so we have to know hemodynamics in order to know where the catheter is. So we're going to put it in a vein. We'll be on the venous side. So if we look at the graph, we have pressure on the Y, time on the X. Initially, pressure is pretty low, and there's not much pulsation. Okay, Swan-Ganz is not a kind of catheter that we utilize to really, if we want to get a good fidelity recording of a venous pulse, it's not the best. And the venous pulse is not that big of pressure change to begin with. So you notice that you have pretty constant pressure that's pretty low. Now, right at point A, notice we see a rise in pressure, drop, rise, drop, rise, drop. We are seeing systole and diastole. So that means we went across the tricuspid valve. The tip of the catheter is now in the right ventricle. Now at point B, notice what happens. Diastolic pressure goes up. So we're still trying to advance the catheter. We're in the ventricle, and then boop, we pass through the pulmonic valve. And we know we pass through the pulmonic valve at point B because diastolic pressure has gone up. Systolic's about the same, but diastolic is higher. So this goes back to the Wiggers diagram. Remember, aortic's 120/80, ventricular's 120/0. Same scenario on the right side, just the pressures are lower. So when we no longer have a diastolic close to 0, we know we cross the pulmonic valve into the pulmonary artery. Then we deflate the balloon, and we keep pushing it until it wedges in, and we can't really move, and wedge it in. Then we blow up the balloon, and that's C, that's pulmonary capillary wedge pressure. This is not the best example of that because actually that pulmonary wedge pressure should be a little bit lower. So we should see a drop in pressure right at C as we wedge it and we're getting pulmonary capillary wedge pressure. But that's okay. Hopefully you can make a little annotation on your book that the pressure should actually go down a little. Normal wedge pressure is about 5 to 8 millimeters of mercury. Pulmonary capillary wedge pressure is our marker of left atrial pressure, which is our marker of left ventricular preload. That's the big key. That's why we measure pulmonary wedge pressure, because it's preload to the left ventricle. All right, let's do the Wiggers diagram. This is a pressure volume loop. Woohoo! Wiggers diagram. Yeah. This is the Wiggers diagram. Remember, the Wiggers was pressure and volume. Well, this is a pressure volume loop. We're taking the two panels of the Wiggers and putting it on a single graph. This is high yield. This is important cardiac function. Pressure volume loop. Now, this loop always goes counterclockwise. So we start at the right, we go up, and then to the left, and down, and around. Always counterclockwise. Heart does two things in systole. It pressurizes and ejects. So here's pressurization, isovolumetric contraction. Notice no change in volume, but pressure's going up. We are pressurizing. Next phase of systole is ejection. We pressurize and eject. So the curve or the loop is going to the left, which means a decrease in volume. We are reducing ventricular volume as we eject. Next phase is the start of diastole, where we are depressurizing. So notice the fall in pressure. That's isovolumetric relaxation with no change in volume. Finally is the filling phase. Two things in diastole: depressurize and refill. Notice the increase in volume of the ventricle as we refill. Now, it should follow. Hopefully it makes good sense. Isovolumetric contraction is the start of systole. Right as that ventricle starts to contract, ventricular pressure is going up, snaps the mitral valve closed. Once the aortic valve opens, we get ejection. So we know at this point, where we start to see a decrease in ventricular volume, we are ejecting blood. That means the aortic valve opened. Systole ends and diastole begins when the aortic valve closes. When the aortic valve closes, the ventricle starts to relax. That's isovolumetric relaxation. There's the drop in pressure. Next phase of diastole is filling, which begins with an opening of the mitral valve. So even if this weren't labeled, hopefully you could work your way through this and know when the valves open and close. When pressure's going up, there's no change in volume. The first thing that happens is the mitral valve snaps shut. So the aortic and the mitral are closed. That's why there's no change in volume. Ejection begins with an opening of the aortic valve. Ejection ends, diastole begins when the aortic valve closes. So the aortic and mitral are closed. pressure falls, that's isovolumetric relaxation. And filling begins when the mitral valve opens. As far as the x-axis and volume, the key points, end diastolic and end systolic volume. End diastolic would be right at the start of systole. And remember, the start of systole is isovolumetric contraction. So that volume, right as we start to increase pressure, is end diastolic volume. That volume, right as we start to decrease pressure, remember, the drop in pressure, isovolumetric relaxation, is the first phase of diastole. So in other words, right at the end of systole. So that volume where we see isovolumetric relaxation is end systolic volume. And remember, end diastolic minus end systolic is stroke volume. So stroke volume is very easy to pick up on the pressure volume loop because it is just how wide the loop is. The wider the loop, the greater the stroke volume. The more narrow the loop, the less the stroke volume. Stroke volume is just how wide the loop is on the pressure volume loop. Alright, pressure volume loops, ventricular function. Here are some key things for you to hone in on. Alright, I drew a little dotted line from this point. What does that pressure represent? Well, that pressure represents aortic diastolic pressure. How do I know that's aortic diastolic? Because once ventricular just exceeds aortic diastolic, then the valve pops open. So wherever the aortic valve opens, that pressure is aortic diastolic pressure. This pressure would represent systolic pressure in the aorta. Remember, peak systolic pressure in the ventricle and the aortic are darn close. So they're very close. So this effectively would represent aortic systolic pressure. There'll only be one exception where they're not very close. Can you think of what it might be? We will talk about it in just a moment. So don't change that dial. I'll come back to it and you will see. We will get there. All right, can we recall what three basic factors affect ventricular output? I hope you tipped your cap to the ventricle for keeping you alive. Yep, contractility, afterload, and preload. They're going to be on pressure volume loops. Expect to be assessed on pressure volume loop as a way to describe ventricular function. And what I'm going to do is give you the shorthand here, the keys to look for contractility, afterload, and preload. All right, for contractility, just imagine a curve that runs through this point, this pressure right at the end of systole. So just kind of draw a curve. Now you might be wondering where I got that curve. Well, I got that curve from a ventricular function curve. Right? If you go back to the previous parts of the book, section 4, where we talked about cardiac mechanics, we have a ventricular function curve. Well, drawing this line in here effectively creates a ventricular function curve. And if contractility shifts, if it goes down, that line is going to shift to the right. If contractility goes up, that line will shift to the left. I'll show you some examples. If it's not resonating very well, you will see an example of this as we go through the valve problem. So bottom line for right now, just draw a line right to that point, a curve. Doesn't have to be a perfect curve, just some idea of a curve. And if that line shifts, then you know you change contractility. All right, afterload for a pressure volume loop is aortic diastolic pressure. Just treat it. We know that technically that may not be right. TPR is afterload. But if we remember from the previous section, diastolic pressure and TPR are directly related. So we can utilize diastolic pressure as afterload on a pressure volume loop. And of course, preload is end diastolic volume. So here's end diastolic volume. We know that's preload. That's Frank Starling. tip your cap to the ventricle for keeping you alive. That's where you hone in. Contractility, afterload, preload. All right, the next aspect we're going to talk about are valvular problems. And here's the bottom lines. Here's the keys to really hone in on as a basis for the valve problems. A stenotic valve is a resistor. All right, it's a resistor. And you will hear the murmur associated with a stenotic valve when the valve is open. Second way we can have a valve problem is it can become regurgitant or incompetent or insufficient. I tend to use the word regurgitation, but it could be stated as incompetent or insufficient. A regurgitant valve means that the valve's not doing what it's supposed to do. Valves prevent backflow. So if I have a regurgitant valve, it's not preventing backflow, it's allowing backflow. And this will create a murmur when the valve is closed because it's regurgitant. Its job is to stop backflow. So if it can't stop backflow, we're going to hear the murmur when it's trying to do its job, which is closed. Now, key thing to remember, hemodynamically, pressure and volume behind the defective valve go up. Now, what do I mean by behind? Again, path of blood flow. The left ventricle is behind the aortic valve because the blood flow goes left ventricle through the aortic valve. The mitral valve, behind the mitral valve is the left atrium. Behind the tricuspid valve is the right atrium, and so forth and so on. So those are the keys, those are the things to hone in on when we're thinking about valvular problems. So let's talk about some valvular problems. All right, the first valvular problem we're going to talk about is aortic stenosis. So we're going to talk about aortic stenosis and regurg, and mitral stenosis and mitral regurg. What we say for aortic and mitral will apply to pulmonic and tricuspid. Just remember the pressure levels are different, and of course the names of the valves are different if we're on the right side. All right, I have a stenotic valve. First thing I think about, is that a systolic or diastolic? All right, a stenotic valve is a resistor. I'm going to hear it when the valve is open. Aortic valve is open in systole, so I'm going to get a systolic murmur. That's the first thing I think about. In this particular murmur, if you look at the waveform, notice that it goes up and then goes down. This is sometimes referred to as a crescendo decrescendo murmur. Now, you may not get that cue on step 1 anymore. I've heard that they've taken it off, but then sometimes they put it back in. If you're reading a clinical vignette and they say crescendo decrescendo murmur and systolic murmur, you're thinking aortic stenosis. All right, stenotic valve is a resistor. So notice the big separation between aortic systolic and ventricular systolic. Ventricular systolic pressure is much higher than aortic systolic pressure. We have a big pressure gradient because I have a big resistor. Okay, so here would be the one time on a pressure volume loop. If you look over to the right, this would be the one time that ventricular systolic and aortic systolic don't match up very well. So as we indicated on that pressure volume loop, we would tell you later, don't touch the dial, don't change that channel. Well, that's your answer. Here is when we would have a big separation between aortic systolic and ventricular systolic. And that's exactly what we would predict. If we have a stenotic valve, it's a resistor, we know that pressure gradient's going to go up. So, systolic pressure in the ventricle will be much higher than systolic in the aorta. Aortic pressure is going to be reasonably normal. All right, mean arterial pressure probably in the normal range, but the more severe the stenosis, the greater the chance that we reduce stroke volume. Notice the pressure volume loop, we have decreased stroke volume. If so, then systolic in the aorta is going to tend to go down a little, and that pulse is most likely going to be less. Because remember, pulse pressure is directly related to the stroke volume. Okay? Notice the high diastolic pressure on the pressure volume loop. So this indicates an increased afterload. Remember that diastolic is what we called afterload. A stenotic valve is an elevated afterload. All right? Big increase in afterload. What kind of hypertrophy do we get with an afterload increase? Oh, hopefully you said concentric hypertrophy, that bad hypertrophy that we discussed in a previous section. If you did, awesome job. This is a big increase in wall thickness. And if I get a big increase in wall thickness, but I don't increase the chamber size, then I reduce function. Now, big increase in wall thickness, that's diastolic dysfunction. So this concentric hypertrophy will cause a diastolic dysfunction. Notice the rise in diastolic pressure. That is one of the key characteristics of diastolic dysfunction. So we're going to have a stiff ventricle. Stroke volume will tend to be down. They're going to have a very difficult time with exercise because they won't be able to increase their stroke volume. Concentric hypertrophy, increased diastolic pressure. Those are the key characteristics. And again, systolic murmur, crescendo, decrescendo murmur. So those are the key characteristics to think about with aortic stenosis. All right, let's go the other way with the aortic valve. Let's make it regurgitant. So now we're getting backflow of blood. We're putting some blood out into the aorta, and then some of it just comes right back in. A regurgitant valve, I'm going to hear it when the valve is normally closed. So if I have aortic regurg, I'm going to have a diastolic murmur. Diastolic murmur. All right? Notice the very high systolic pressure in the aorta and the ventricle. All right, that is indicative of a very big stroke volume. Notice the big stroke volume and the high systolic pressure in the pressure volume loop. Notice also the low diastolic pressure on the pressure wave on the left and on the pressure volume loop. So we have a whopping pulse pressure. Aortic regurg is characterized by a whopping pulse pressure. The other thing to note is the last arrow that came in. Notice that there is no sharp change in volume, isovolumetric relaxation. So key characteristics on this pressure volume loop. Contractility is still okay. We have a big increase in stroke volume, big pulse pressure, and the rise in volume when there should be no change in volume, isovolumetric relaxation. So those are the characteristics, those key characteristics. High systolic, low diastolic, no isovolumetric. That is just telling, that is just screaming to you aortic regurg. All right, big stroke volume. So we have a whopping pulse pressure. Systolic's high because of the high stroke volume. Diastolic is low because we have very low volume in the aorta at the end of diastole. Hopefully you remember that is what determines diastolic pressure. Well, we're going to have a very low volume there because it's two exits, no waiting. We put blood out into the aorta. Some of it goes to the periphery, but some of it can just jump right back into the left ventricle. So two exits, no waiting, very low diastolic. So again, this is going to create a whopping pulse pressure. And so you can often feel that. So you're feeling a pulse, and you feel this sudden rise, and then boom, all of a sudden it's gone. Just suddenly goes away. So quick ride, and then boom, gone. Big pounding pulse. Very characteristic of aortic regurg. This is a great example of a volume overload. And hopefully you remember the type of hypertrophy with a volume overload. Yeah, you got it. Excellent. Eccentric hypertrophy. So this is causing an eccentric hypertrophy, which is not a big increase in wall thickness. Okay, so it's not getting that stiff, but it is a volume overload and it will hypertrophy some. So those are your key characteristics of aortic regurg. Don't forget that big pounding pulse. And if they show you a pressure volume loop where you see a big pulse pressure and no true isovolumetric relaxation, bingo, aortic regurg. All right, next is mitral stenosis. In mitral stenosis, we have a stenotic valve. I'm going to hear the murmur when the valve is open. Mitral valve is open and diastole, so we're going to have a diastolic murmur. So looking at the pressure waves, aortic pressure not really affected. What am I going to see? Big effect pressure waves. Difference between atrial and ventricular pressure. This, of course, makes complete sense because the stenotic valve is a resistor. So I'm going to see a big pressure drop across the resistor. Upstream pressure goes up when I increase resistance. Upstream is left atrium. So left atrial pressure is going to be high, much higher than left ventricular. Again, diastolic pressures. Big separation in pressure. I know I have a resistor. It gives it away. It's mitral stenosis. Now don't forget, left atrial pressure is venous pressure for the lungs. So this rise in left atrial pressure, we start worrying about pulmonary edema because of the rise in pulmonary capillary pressure. And that's one of the concerns as mitral stenosis gets more and more severe, is the idea of pulmonary edema. Notice on the pressure volume loop that we have a reduction in preload. This reduction in preload is causing a reduction in stroke volume. But notice, if I draw my little line here that we described for pressure volume loops, you can see that contractility is unaffected. So the reduction in stroke volume is simply because of a reduction in filling. We don't have a higher pressure, so it's not diastolic dysfunction. We don't have diastolic dysfunction here. Left ventricle is functioning just fine. The problem is I can't get blood from the left atrium to the left ventricle because of the stenotic valve. Contractility is fine. The decreased stroke volume is just because of a decrease in end-diastolic volume. It is a Frank-Starling mechanism. Now, just as with aortic stenosis, these patients, when you exercise them, you can really manifest the problem. Mitral stenosis, aortic stenosis, output is compromised. In mitral stenosis, the reason that output is compromised is because filling is compromised. As I do a flow demand like exercise, I won't be able to get that blood from the left atrium to the left ventricle to get adequate output for the big increase in flow demand associated with exercise. So they might get a little syncope. They are also likely to feel congested, have difficulty breathing because I'm putting more volume in the lungs. Left atrial pressure is elevated, potential for pulmonary edema. So those are big key characteristics for mitral stenosis. Again, a diastolic murmur. And something else you may see in the clinical vignette on this would be something called an opening snap. If you read that in a clinical vignette, opening snap, you're thinking mitral stenosis, as opposed to a click, and a click suggests mitral valve prolapse. So a click is prolapse, a snap is mitral stenosis. Okay, going the other way with the mitral valve is mitral regurg. This is backflow of blood, so I have a regurgitant valve, That means I'm going to hear the murmur when the valve is normally closed. Mitral valve is closed in systole, so I'm going to get a systolic murmur. Now, notice the representation of this systolic murmur. It's relatively continuous. So, with aortic stenosis, we had a crescendo decrescendo systolic murmur. Well, we're going to have what's called a holosystolic or pan-systolic murmur. Holo, pan means throughout systole. So we have a continuous murmur throughout systole. It's not increasing in pitch and decreasing in pitch like aortic stenosis. It's a continuous holosystolic or pan-systolic. So if they give you that on a clinical vignette, then think immediately mitral regurg. All right, we're kicking some blood back into the atria, so notice during ventricular systole, atrial pressure is going up. This can be very severe if it's acute. So if we have an acute problem with the mitral valve, it becomes regurgitant. Example, I hope you said myocardial ischemia. Exactly. So if we're having a heart attack, we're having myocardial ischemia. Those papillary muscles can get damaged and a patient can basically just blow their mitral valve. In that case, atrial pressure is going way up and can be very significant. And so if you get a very acute big mitral regurg, you're really, really worried about pulmonary edema. If we go over here to our pressure volume loop, what's the key characteristic I'm going to see here that's going to separate this so I know immediately it's mitral regurg? Notice no true isovolumetric contraction. Do you see how the curve just kind of rounds off? What should be a steep, straight up and down, very vertical line. Notice how it rounds off. So that is a key characteristic, no true isovolumetric contraction. And that's because we're losing volume into the left atrium. We do have a big stroke volume, but we don't have a big pulse, so that gets rid of aortic regurg. And it's the isovolumetric contraction phase that's affected, not the isovolumetric relaxation phase. Remember, in aortic regurg, we didn't have a nice vertical isovolumetric relaxation. In mitral regurg, we don't have a nice vertical isovolumetric contraction. Just think about where the blood is going. Last but not least, we have a reduction in systolic blood pressure. There's also a reduction in contractility. Draw in your little lines, your contractility lines, and you will see there is a marked reduction. There's a right shift in contractility. Remember, you draw it using that point at the end of systole. If you were to draw in those lines, you can see that that curve is shifted markedly to the right, meaning decreased contractility. The heart loses contractility because it's pumping blood back into the left atrium, which is much, much lower afterload than the aorta. So it's like the heart is kind of taking a break. It's not exercising as much because it's pushing blood into a low resistance circuit. And that's why contractility falls. All right, so those are your key characteristics, things to look for, things to remember, things to know for mitral regurg.